PGI May 2012, the summer with the hot scorching New Delhi reaching Chandigarh to take the exam. MHC 2, where is it located? Macrophage, dendritic cell and lymphocyte, what is the common thing for all of them? They are called professional antigen presenting cells is what you need to remember. And there is a MHC class 2 overlying it. Then, where is MHC class 1 located? On all the nucleated cells. That's the reason in all cells, but RBCs, they are typically located is what you need to remember. What is a single gene disorder? See, JIPMER also, this was a favorite MCQ, JIPMER November 2014. Single gene, multifactorial, two types will be there. Colon cancer, Huntington's disease, Duchenne, all of them are single gene disorder. But if you look at the type 2 diabetes, it is basically what? Multifactorial disorder is what need to be remembered. One question on primary immunodeficiency, any PGI aims you go is a common question. WiskottAldrich, ataxia telangiectasia, severe combined immunodeficiency, Job syndrome, IgA deficiency, so IgE deficiency, all this you must be sure, doctor. So basically, severe combined deficiency is both B and T cell. WiskottAldrich primarily is cell mediated T cell, but it also has got the B cell deficiency also. That's the point about the WiskottAldrich. So what are combined T and B cell immunodeficiencies? Severe combined immunodeficiency. Then predominantly antibody but not cell mediated. Which disorders come under this important group? Basically you have conditions like transient hypogammaglobulinemia, then you are having there are a lot of other disorders where hyper IgM syndrome it is called. In all these scenarios the whole problem is only humoral but not cell mediated. Then if you take WiskottAldrich, fundamentally the problem is in this you have got it's a X-linked disorder. You have got repeated sinopulmonary infections along with thrombocytopenia as a clinical triad. You have a low serum IgM, favorite MCQ of examiner. Low count hota, normal count hota, elevated count hota. IgE is increased, IgA, IgG are normal and IgM is low. That characterizes typical WiskottAldrich is what you need to basically remember. Prolonged APTT. Factor 7 होता है PT, 2, 5, 10 is common, 8, 9 everything else is APTT. So whenever fibrinogenemia, antiphospholipid syndrome or viper snake bite, hemophilia A, in all these scenarios you have APTT prolongation. Estrogen lead to hyperthrombotic state, prothrombotic state, not bleeding diathesis or APTT prolongation. What is a horseshoe kidney? So basically there is a fusion along the lower poles, there is a fusion of the kidneys, and where does this fusion occur in relation to mesenteric artery? It occurs below the mesenteric artery. Mesenteric artery arises from, anything should arise from aorta only, no? So उसके नीचे होता है commonly is what you have to basically remember. So it's a typical radiograph. Sometimes a image based MCQ can be a radiograph like this is given and asked about what is accept about this entity. First you need to diagnose that normal position में नहीं है, kidneys they have descended down is what you should recognize. Then they descended down means common high yield topic in entrance is horseshoe kidney. So possibly examiner want to know about horseshoe kidney. So I'll give you one MCQ created on this. How does tumor cells evade the immunogenic response? By what mechanism? It is the decreased expression of the MHC1. MHC1 is shown on all nucleated cells. MHC1 cells अगर tumorous हो गए तो, में कुछ alteration आ गए तो immediately our immune system पकड़ लेगा. मगर malignant cells क्या करते? They are fastly replicating. They should not know. They should not let the immune system know that. Hence they will downregulate their own MHC class 1. Who said God is not there? It is a God who told malignant cells to bring down the class 1 expression. Then similarly, but one thing is there. If you take NK cells, natural killer cells, they don't need the MHC class 1 expression in order to पकड़ने के लिए malignant cells को. इसलिए tumor surveillance is one of the important functions of the NK cells is what need to be remembered. Then another fact about NK cells क्या होता है? Normally antibody protection के लिए prior antigen sensitivity होना, तो they are not antigen sensitivity restricted. So ADCC, antibody dependent cell mediated cytotoxicity, they can behave like B cells in producing antibodies and they can behave like T cells in producing cell mediated immunity. दोनों abilities होता है NK cells में is what you have to basically appreciate. The next question is on NK cells. NK cells apoptosis compulsory topics है. तो they are CD16 56 positive. अब CD list बना के ready है exam के लिए. छोटा छोटा चीज will bring all difference doctor. Small lists which are commonly asked, मगर मैं भूल रहा हूं. So how to do that? You prepare your own 100-150 lists, personal list, and try it on your friends. सबके ऊपर abracadabra, give a tail, abracadabra, give horns. Like that you try it on your friends in the reading room. वो अगर आप practice कर रहे तो आदत हो जाता. नहीं तो if you postpone suddenly all that memory, I have to load it on brain in the last moment बोले तो there are some inevitable lists. You can't help it out. Like going for a vacation with the kids. You have to take paracetamol, you have to take amoxicillin, you have to take ear drops. वो सब एक बड़ा लंबा list रहता है. Tomorrow when you are running families. So no role in cell mediated immunity, NK cells. They are capable of doing cell mediated and also antibody production. That's the point actually. So adult polycystic kidney disease, ADPKD. So basically it shows autosomal dominance pattern. It is a 2 gene mutation which is responsible, and loss of first mutation के वजह से heterozygosity आ जाता. एक mutant allele, एक normal allele रहता. Second mutation क्या करेगा? वो heterozygous state को दोनों alleles mutant alleles बनाएगा. Then the condition will come out. Retinoblastoma, osteogenic sarcoma, ADPKD. There are some entities where this 2-hit hypothesis of Knudson, KNUDSON, is very important, is what need to be remembered. So doctor, ADPKD 2 is on chromosome 4, ADPKD is on 6, ADPKD 1 is on 16. So how many chromosomes are involved in ADPKD? Ultimately it is chromosome 4, chromosome 16, but 85% of times it is chromosome 16 which is associated with ADPKD is what you need to remember.